Our current overdoses in Canada, which have topped 21,000 in 5 years, are a completely predictable result of Canadian drug policy, which follows American policies on the war on drugs. So when you're asking how did we get here, we actually need to rewind about 100 years actually.
This is the Public Health Insight Podcast.
Hello everyone, my name is Gordon and I'll be your host for this episode along with Ben and a very special guest.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
Dr. Andrea Sereda is a family physician working at the London Intercommunity Health Centre, where she focuses her practice on people who use drugs, people living in homelessness, and women involved in the survival sex trade. Dr. Sereda provides care in a traditional office setting, but also through street outreach medicine, going to where people are at in shelters, encampments, or anything in between. She's an avid harm reductionist and is the lead physician for the London Intercommunity Health Centre Safe Opioid Supply Program, which is currently the longest running of its kind in Canada. Please join me in welcoming to the podcast, Dr. Andrea Sereda. Dr. Sereda, thanks for taking time out of your day to join us to talk about several important issues smushed up into one. But we'd like to know a little bit more about you and the work that you're passionate about. So if you could start by telling us, why you decided to pursue a career in emergency medicine and ultimately how you arrived where you are now.
Absolutely, and thanks for having me, Gordon and Ben. So it's been a bit of a journey getting to the practice that I hold right now. So as you mentioned, I actually started my career in a combination of working in the emergency room and some family medicine work as well. My family medicine work has always encompassed marginalized populations. So I actually, coming out of med school, started a practice in one of our local homeless shelters at the Centre of Hope here in London, Ontario. And I actually did that because of my little brother. So my brother Jason Sereda was working on a floor, essentially in a social work type of role. And I needed a part-time job in med school. So he told me about a few postings. I was hired and worked the overnight shift on the detox, the withdrawal floor. And it really was my first exposure to people who use drugs, people who are, using street level substances, people living in homelessness. And the experience was pretty profound. It really, I think, altered the trajectory of what I thought I would do with my career. So again, graduating from residency, I had always planned to do Emerge, but then actually added that family practice component. Did that for quite a few years, I think 6 or 7 years I was in Emerge. And then a really amazing opportunity came up at the London Intercommunity Health Centre. So LIHC is involved in a really unique program called Street Level Women at Risk, which is a partnership between Housing First organizations, medical, and policing. And the doctor who was involved in that, Dr. Ann Bodkin, was a mentor of mine. And at that point, she decided, retirement was what she wanted. And so that opportunity opened up for me and I leapt at it. And that's when I became to doing the full-time work with London Intercommunity Health and at the beginning really working again with women who were involved in street-level sex work and then people living in homelessness and the rest of the practice grew, and I'm sure we're going to talk more about that.
For sure. Thank you, Dr. Sereda. Could you share a bit more about the London Intercommunity Health Centre and your role as a day-to-day physician there?
Absolutely. So London Intercommunity Health Centre, we're a CHC, which is a community health centre. CHCs are across the province of Ontario and actually across Canada. And all CHCs, we have a mandate to care for people with barriers to care in the traditional health system. So our clinic itself, LIHC, serves about 8,000 patients in London, Ontario. My corner of it is, again, we in the clinic called Health Outreach, and that's where we're working primarily with people who live in homelessness. But there's many other different groups of folks who are served in our clinic. So we do have a very large newcomer population in practice that serves in the community. We see many undocumented folks. We see many people living in poverty, and then many people who, for whatever reason, fall through the cracks in more traditional family medicine offices.
That's awesome. So that brings it full circle to one of the things I was curious about. You identify as an avid harm reductionist. So first of all, what does that mean to you when you say avid harm reductionist?
Yeah, so harm reduction, the term actually did originate in substance use and, street level drug use. And it was looking to acknowledge that people who use drugs are able to have the autonomy to continue to do so in a way that, serves their goals and their needs. But with drugs, just like many other things that we choose to do in life, there are risks and there are potential harms. So harm reduction accepts that individual's choice to use drugs, but seeks to, provide tools and education and medical care that addresses any potential complications of it. The first harm reduction measure that we saw in Canada was actually emerged out of the downtown east side in Vancouver in the 1980s when they were having the first HIV epidemic here in Canada. And that was a clean needle exchange program. And so that came actually out of the community of people who use drugs themselves, acknowledging that their drug use, was related to the acquiring HIV sometimes, and then seeking measures to reduce that potential harm. And then everything else that we're doing within, substance use work follows that narrative as well. And I guess an avid harm reductionist just means that I've drank the Kool-Aid and I'm all in, I'm 2 feet in.
Awesome. So John Dewey is an American philosopher, and one of the quotes that he said that always stands out for me is, a problem well defined is a problem half solved. So when we're speaking about the so-called opioid overdose crisis, or some say it's an epidemic, how did we get to this point? And was there a singular root cause for how this all came together?
That is an absolutely enormous question, Gordon, that I could write an essay on. But and actually this is something that I often try to correct in my media. Is you're correct. We have to define the problem properly, because I really believe the language that we use to describe a problem really informs the solutions we can think of. So there's kind of a couple of prongs to answer your question. The first is what are we really dealing with? You mentioned, I think, the overdose epidemic. You also called it an opioid epidemic. I shift that a little bit, and I refer to it as a drug poisoning epidemic, which we can delve further into, but also a drug policy epidemic. Our current overdoses in Canada, which have topped 21,000 in 5 years, are a completely predictable result of Canadian drug policy, which follows American policies on the war on drugs. So when you're asking how did we get here, we actually need to rewind about 100 years, actually. So beginning with alcohol prohibition and, leading into Harry Anslinger's actions in America around, marijuana and reefer madness and everything else. But what we saw in the 1920s with alcohol prohibition actually completely mirrors what we're seeing with opioids and fentanyl right now. So in the 1920s, when Prohibition was brought in, the drink of choice at that time in America was actually beer. So a low concentration, a low potency alcohol drink that, was widely imbibed in America. With Prohibition, beer became really hard to conceal and smuggle, right? You needed a lot of volume to meet people's needs and speakeasies. So people very predictably switched to a more concentrated product that they could ship smaller volumes of and therefore meet the needs of people in a smaller container. And so the drink of choice in America really shifted from beer to spirits, like whiskey and vodka and rye. And that pattern of American alcohol consumption actually, continued in that direction. So Prohibition really shaped the type of alcohol that people at the time were trying to consume because it was outlawed. We've seen lots of that, around opium and around marijuana, and we don't have time to go into all of it. But when we think about what's going on with opioids, it's the exact same issue. So a lot of the media is around doctors overprescribing. And certainly there's a lot of issues, particularly around OxyContin and other drugs. But what we need to remember is that people have been using opioids, opium, since time immemorial, right? Again, in the early part of the 1910s, people would drink opioid tea and other things, very low potency drugs at that time. When we're moving into, the 2010 to 2013 era, when people were recognizing the impact of OxyContin on some folks, the reflexive reaction from government and policymakers was to reduce that supply. So lots of prescribing guidelines came out to physicians telling them to, cut people off or significantly cut back their prescriptions. Government actually pulled, the Ontario government at least, pulled OxyContin from the provincial formulary in, I believe, 2013, 2014. And exactly what happened with alcohol prohibition, people didn't stop using this drug. They're dependent on this drug. They use these drugs for multiple different reasons in their life. But then they no longer had what at that time was their safe supply, right? A known dose prescribed by their physician of a pharmaceutically made drug that was clean, that was pulled away from thousands of people in Canada. They didn't stop using opioids. They then just turned to the street market. So very predictably around 2015, we saw the emergence of fentanyl because, the standard opium that people really think about is heroin. Heroin is, compared to fentanyl, shipped in very large volumes, hard to conceal, takes a lot of work to get over borders, whereas fentanyl can be shipped in grams, right? And then cut down to tenth of gram, which is what people use. So exactly like the alcohol shift from beer to spirits, we saw people switch from pills to street-based fentanyl. And that was a direct action directly related to government policy about pulling the other medications.
You mentioned a term that really stuck out to me, and that was drug poisoning. And from your experience, did you find that the audience was more receptive to this term? Because, historically, we had the crack epidemic, the opioid epidemic. People may not be familiar with these drugs unless they're in the healthcare field, and they might say, these are people who use drugs and they're using this drug and that's their problem. It doesn't affect us. But when we take that term drug poisoning, people are like, oh, what's going on here? Why are they being poisoned? Did you find that at all?
Yeah, I think I definitely have to explain the term and where I'm going with it. So again, I'm gonna keep bringing it back to alcohol, right? So right now, with alcohol being legal, you buy your safe dose, known concentration, you know what you're doing. You can go to a safe consumption site for alcohol, which is a bar, and really imbibe in your drinking the way you want to. But because opioids are illegal for street level consumption, we're dependent on the black market. And so when you're thinking about fentanyl, it's not actually fentanyl that is killing people. We use fentanyl in the hospital every single day safely. It's used in emergency medicine procedures, it's used in anesthesia, it's used for pain control, and it is completely safe because it is a known purity and a known dose prescribed by a doctor. But when you have street-based fentanyl, people don't know what they're getting. I often, talk to my patients about it this way. I say, fentanyl is like a batch of chocolate chip cookies. So if you're not mixing the batch very well, you could end up with a cookie that has 2 chocolate chips and a different cookie that has 20 chocolate chips. They're all coming from the same batch, but you don't really know which one you're going to get. And fentanyl is like that. The fentanyl is unequally distributed through a batch. So 2 people could be smoking, from the same batch of fentanyl, but one person is going to go down from an overdose and the other person isn't. Again, because of that variability in concentration and people not knowing which end of that they're going to get, right? And then along with that comes all the cutting agents that are in fentanyl. The average, point of fentanyl sold on the street is only about 8% fentanyl. So it's 92% other crap, right? And that's leading to poisonings and, health complications as well. So people are poisoned by consuming an unknown drug, essentially. Okay?
Right. So the point you're making here is that there's the opioids, and then there's the unknown quantity and concentrations, which actually causes the severe negative health outcomes that the person doesn't knowingly ingest or into their body. So
Correct.
By saying overdose, it implies this person probably wanted to take a lot when the intention was maybe they use the same amount of what they thought they were getting, but they're just essentially blindsided by other substances as a consequences of needing to get it from uncontrolled street supply. compared to a medical
That is
grade.
a perfect summary. Perfect summary. And so you're completely right. If you think of the origin of the word overdose as well, you're using too much of a dose. That's what an overdose is. You're ingesting more than you intended to ingest. And I can tell you, my patients don't intend to overdose. These are all unintentional drug poisoning overdoses. Again, they purchase an amount, they think they know what they're getting, and they get something else. That's drug poisoning.
So this is a perfect time to bring up the misconceptions about there's different types of technical terms for a general audience that might be a bit confusing, like addictions, substance use, problematic substance use. Is there a way you can easily draw a line between those that can help people conceptualize?
Drawing a line, probably not, because it's all a spectrum, and it all, depends on the angle that you're looking at it from, right? And so certainly when people look at my patients, they say they're addicted, right? They say they're addicted, or they say they have chaotic substance use. I just say they use substances, okay? Some people, again, just like alcohol that's legal, will use too much alcohol and will have negative health or potential social, consequences of that. That's the definition of addiction, ongoing use despite consequences. The majority of people who use alcohol are not in that group. The same is true of street-level substances. The same is true of fentanyl. Yes, we do have a proportion who are addicted. The rest of the folks use substances for various reasons in their life, okay? For example, my patients, at least 60% of people on Safe Supply are homeless. So I want you to imagine that you've been sleeping on the concrete for 3 years, winter, fall, summer, all kinds of weather, rain, sleet, snow. You don't have any shelter. You maybe sometimes have a sleeping bag or a tent. And after 3 years, your back really hurts. And so you can't get a prescription from your doctor because they call you drug seeking and they judge your intentions for that use. So you go to the street supply and you treat your own needs. And many other things, right? Heroin is called a warm hug, and it's called that for a reason. Opioids treat not only physical pain, but they treat emotional pain. So again, imagine you're the same person sleeping on the street for 3 years. You're watching the community step over you. You're watching other people go into houses and have enough to eat, and you don't have any of those things, and you're completely isolated from the rest of the community. Would you want to blot that out with drugs? I think I sure would. And so sometimes people turn to substances for that reason. And then there's a lot of trauma, right? So many people, in the experience of homelessness or living on the street or, experiences that predated that, they're trying to block it. We don't have effective therapies. They don't have access to doctors or other professionals who could help with those things. They treat their own symptoms. So are people addicted? Yes. Are people who use fentanyl regularly physiologically dependent on that drug? Absolutely. But that's different from addiction. And I find in my practice, most people are meeting their own needs, whatever that is. And we can talk about how we make that better for them when we get to actually talking about safer supply.
So that brings up the question. I one of the things that I constantly hear you trying to correct is that people have a misconception that the drug use happens before the social exclusion, the social deprivation, the housing deprivation. But what you're saying is that's a means of coping with the emotional, physical trauma associated with maybe not having the same access to those resources as other people, rather than the other way around.
Absolutely. And certainly nothing is black and white in life and humanity. But yes, there's this general perception in, the lay population that people use lots of drugs or they're mentally ill or they're doing bad things. And that means they end up homeless. And that's where they're like, to fix homelessness, we need more mental health treatment and, more rehab centers, when it's really ass backwards, right? So people are homeless because they don't have enough money to rent or buy a home. Full stop. Homelessness is poverty. And you can argue about all the, reasons people get to that level of poverty, but you don't have a home because you don't have enough money to have a home. And so you end up on the street, and just like I said, you undergo new physical and emotional trauma, and your mental health starts to suffer. right? I mean, again, if you were sleeping on the street for 3 years, how depressed would you be? How anxious would you be? Would you start seeing things because you've slept 2 hours a night for 3 years, right? Of course you would. And so your mental health deteriorates, and often people's substance use either, starts or gets worse on the street for the exact same reasons that I've described. And one of the things that we see with the Housing First component of our program is so much mental illness and substance use gets so dramatically better when people are housed. Again, it's not black and white, but I think we really need to reflect on the reasons that people are ill when they're living on the street, and really stop needing to assume that they're personal choices and personal failures that are leading to that. It's a systemic failure. We're all involved.
And one of the things I wanted to follow up on, I heard you on I think it was a CBC show lately, and you mentioned that so we have opioids, and then you also mentioned crystal meth is often used for people who are maybe housing deprived, living on the
100%.
streets, a little bit scared to sleep. So we don't think of people using substances as a way to cope necessarily while they're living in housing precarity. But you make a great point that actually this brings someone further down the rabbit hole of needing to use even more to be able to just cope with the daily realities of being out on the street.
And I know which interview you're referring to, and I think I mentioned it even in the context of women, right? So if you're a woman who is homeless, again, you're living on the street, maybe you're living in a tent, maybe you're living in a group, maybe you're living solo, it can be really dangerous for you to fall asleep in that environment. You're prone to theft, physical, sexual assault. And so you use crystal meth because it keeps you awake for 2 or 3 days and keeps you safer from those things. And obviously there's implications both from the crystal meth use and, from being awake for those long periods. But I think, again, we're reflecting back on what is actually the need that's being met. And then again, you're sleeping 2 hours a night because the concrete is uncomfortable and it rained all night. Crystal meth is often used like a coffee for my patients. They may have a little toke, a little puff in the morning, and it wakes them up just like the espresso I make at home. And that can be a mechanism of use. And then again, at the far end of the line, sometimes people are just so distressed by the way they have to live that they don't want to be part of it. And so they blot out and they use drugs and they seek euphoria and being high for that reason. Again, I don't think we have a moral leg to stand on by criticizing people for doing that until we actually have, a Canadian society that supports the basic human rights of everybody who lives here.
Absolutely. And I wanted to follow up with that because we talked a lot about, this existing condition that they have to face every day of their life 24/7. And now with the elephant in the room of what we've all been dealing with for the past 16 months with COVID-19, in your experience, how has this worsened the situation?
So it's worsened it, but it's also exposed the gaps in society, right? So COVID has been hard on everybody, but again, imagine you have nowhere to go home to and all of the services have shut down. So in March 2020, when we started to enter that period of lockdown, basic programs shut down for my patients. So hygiene programs, nobody could have a shower for 6 weeks because everything was closed. There were no bathrooms. People had to, do their business number 1 and number 2 in the forest, in the bushes, because there were no bathrooms that were open. Meal programs reduced because a lot of our meal programs are actually staffed by elderly folks who are told to isolate for the risk of COVID. And so people who are normally able to maybe find 2 hot meals a day through various, now are down to 1 if they're lucky, and it's a sandwich that you eat on the street, right? So again, put yourself in that situation. How would that feel? Again, we've all suffered, but it's so much worse when you're on the street. And again, it exposed a lot of inequities because my folks were the only people who were out and about. So suddenly people are seeing these usually invisible humans, but without the other humans around them, they're more obvious. And it also just exposed the massive lack of housing that we have in almost every Canadian community. If you're told to self-isolate, and you don't have a home, what would you do, right? We have no options for these folks.
Right, and moving forward, a lot of people have been laid off due to the pandemic. They might have lost their homes as well. So this crisis gets even worse coming out of this, right? And then if we have services and resources that haven't been established or have been reprioritized to COVID-19, it seems like it's just adding more kindle to the fire.
Absolutely, yes.
So in theory, we would expect that the situation, there's more of a strain on our society because you mentioned the gaps have been exposed. So has this translated to an actual increase in the number or the rate of drug poisonings or toxicities?
Yes. So it's hard to know what is causation and correlation, but we certainly know the trends that run together. And at the beginning, comparing 2019 to the 2020 rates of overdose, we saw a 60% increase, and that was consistent across Ontario. The reasons for that are complicated, again. There's a lot of despair. There's a lot of people trying to cope. So therefore, there's more drug use. There's higher volumes of drug use. That can lead to more drug poisonings. But then if we think again about the services that folks need, our safe consumption facilities, because of, very important distancing rules, could see less people. So you might have had a safer consumption site that had 5 booths for people to use in that could have 5 patients at the same time. Now, because they have to use 6 feet apart, they have 3 booths. So no longer can as many people be moved through that service to safely consume their drugs. Also, with the advice of self-isolation, right? You have a lot of hidden homeless folks who were maybe crashing on somebody's couch, right? And that's called couch surfing. People didn't want to do that anymore, right? They wanted to self-isolate if they had a home. And so a lot of these folks who were couch surfing were now out on the street and, had their use and their potential overdose rate impacted by that. And then there was also something that emerged out of COVID in that many cities across Ontario, at least, instituted policies called COVID hotels. And so because shelter space was rationed and socially distanced, the federal government did provide money to put folks who are living with homelessness in hotel rooms for the purpose of self-isolation. And that's wonderful because they have a roof over their head, and it's complicated, and that's probably a whole nother podcast. But also you take people who are using drugs in groups and communities in order to stay safe, in order to, intervene if their friend has an overdose. And now you're getting city policies that say 1 person per room and no guests. And so people who would usually use collectively and receive naloxone from their peers are now using in isolation by themselves in a hotel room with nobody to respond to them if they go down. And certainly I know of many folks like that who had, more or less safely used substances in either a shelter or street level capacity who were put singularly into a room and overdosed very shortly thereafter and died.
You have just heard part 1 of Gordon and Ben's conversation with Dr. Andrea Sereda about the genesis of the drug poisoning crisis, its similarity to the alcohol prohibition period, some reasons people use opioids and other substances, and COVID-19's impact on harm reduction services. Join us in the next episode as Dr. Sereda shares her experience as the lead physician practicing street outreach medicine for the London Intercommunity Health Centre Safe Opioid Supply Program, which is currently the longest running of its kind in Canada. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our content and would like to stay up to date, follow us on Instagram, Facebook, Twitter, and LinkedIn. To learn more about our community initiatives and how you can support us, visit our website at thepublichealthinsight.com. Join the PHI community, and let's make public health viral.